Morning, ladies and gentlemen. It is my great honor to join you at the World Federation of Ultrasound Medicine and Biology webinar 2021. I'm Yihong Chou. I'm from Taiwan and now serving as a chair professor at WFUMB University in Taiwan and Taipei Veteran General Hospital. Here is a hospital where I have been working in for more than 40 years, a 3,000 bed hospital in Taiwan, Taipei. In the following 20 minutes, I'm going to discuss with you about RFA of hepatic tumors, contrast-enhanced ultrasound evaluation for RFA efficacy. Outlines: introduction, imaging modalities for assessing hepatic tumor response to RFA, and the usefulness of contrast-enhanced ultrasound or CEUS in the planning of hepatic tumor, RFA, and the evaluation of RFA response, and then pros and cons of CEUS, and then conclusion. As you know that RFA is nowadays one of the most important minimally invasive procedure for treating hepatic tumors. It is considered the first-line treatment of choice for small to medium-sized primary and sometimes secondary malignant hepatic tumors. It is particularly suitable for recurrent hepatocellular carcinoma after surgery. In the hospital where I'm working in, or the Veteran General Hospital, we introduced RFA to treat patients since 1999. And from 2002 to 2013, we have been doing RFA procedures for more than 3,000 and about 2,400 of HCC patients were treated in our hospitals. And now, almost every year, we have about 800 procedures for RFA of hepatic tumors. Here you can see the percentage of hepatic RFA is the most commonly treated tumor in our hospital. So before talking about the RFA for HCC, we have to know that if incomplete ablation of RFA was done, can it cause more aggressive tumor biology? Here you can see some studies demonstrated that incomplete ablation may stimulate epithelial mesenchymal transition in hepatocellular carcinoma. And heated human HCC cells may cause increased PCNA and decreased E-cadherin, and also in turn cause enlarged tumors and increased lung metastasis possibility. And some studies also demonstrated that in HCC patient post-RFA with recurrence, the TGF-beta level or twist or SNEL1 and so on can be increased. So that's quite suggestive of the possibility that incomplete ablation may cause aggressive tumor biology. So local incomplete treatment or non-lethal heating can increase the metastatic biology, was also demonstrated. And non-lethal heating of HEPG2 tumors may cause may cause increased expression of markers associated with metastatic behavior. Therefore, we have to do the right thing at the first time. That means we have to treat tumor completely instead of causes a residual tumor to be more aggressively enlarged or recurrence. Now, about image modality for assessing hepatic tumor response to RFA, we have a conventional cross-sectional image modalities, especially ultrasound CT and MR. Contrast-enhanced CT and contrast-enhanced MR are very important, particularly the MRI with DWI and ADC, and also we are commonly using the gadolinium EOB DTPA enhanced MRI for evaluation of tumor treatment response. Now we can have also contrast enhanced ultrasound. It can provide us real-time monitoring for the liver tumor treatment evaluation. So in Taiwan, we have 3 different contrast medium available. That include Sonoview, Sonozoid, and Definity. Now we have more experience about Sonozoid. We use Sonozoid to do pre-RFA evaluation of focal liver lesion and intra-procedural monitoring and immediate post-RFA assessment, and also for post-treatment follow-up study. Now I'm going to show you some examples. This is an example for evaluation of a tumor size by using CEUS. Here is a lesion, actually hyperechoic, identified here, and after contrast enhancement you can see the lesion well enhanced, hyperechoic and well enhanced after contrast injection. Now we compare the pre-contrast injection. It's about 1.6 by 1.2 centimeter, but after contrast enhancement, it measures 2.1 by 2 centimeter. That means the real size is bigger than we expected without contrast enhancement. Another example to evaluate tumor size by using CEUS. Here is the tumor, radial hypoechoic, on the background of liver cirrhosis. And after contrast enhancement, here you can see actually not only this larger tumor, but beyond the territory of the tumor, we can see another well-enhanced area, suggestive of the tumor breakthrough the pseudocapsule extend outside to the initial tumor. So if the lesion does not exhibit a washout during the portal and the late phase, the lesion is most likely benign solid lesions if it is obvious overt SCC. But here the lesion is well enhanced, so that's definitely corresponding to the extension of the initial tumor to the other part of the liver. Now here is another example for tumor size evaluation or extension evaluation. Here, a hypoechoic lesion in the right hepatic lobe. The initial measurement is about 2.8 by 2.7 centimeter on the background of liver cirrhosis. And after contrast enhancement, in the late phase or Cooper phase, you can see the tumor washout. But here you can see another tiny hypoechoic zone in the Cooper phase. But grayscale ultrasound cannot depict the pathology. So again, we do second injection or so-called reperfusion CEUS. We demonstrate that the hypoechoic zone is well enhanced. That means that's a daughter nodule. So we can use CEUS to demonstrate this kind of small tumor. And grayscale ultrasound, difficult to depict focal pathology or those suspected hypoechoic or hyperechoic zone somewhere in the cirrhotic liver. But contrast enhanced ultrasound well demonstrated hypoechoic or non-enhanced area in the Cooper phase. That's suggestive of HCC. So we do ultrasound guided biopsy during the Cooper phase and demonstrated that both lesions are HCC. And some study also demonstrated that increased tumor conspicuity in 31 HCCs among the 43. Therefore, about 72% of tumors are showing increased lesion conspicuity by using contrast enhanced ultrasound. Now, here is an example to show you that intraprocedural monitoring and immediate post-RFA assessment of a hepatic tumor. Contrast enhanced ultrasound demonstrated a hypervascular, hyper-enhanced lesion in favor of HCC, and then washout in the central zone. And after RFA, we found some areas with relatively hyper-enhanced. So we do second needle ablation in this area with increased enhanced to treat this. So after the first procedure, we do a second procedure for this area. And this is during the second needle ablation. And after the second needle ablation, here you can see the territory of the ablation zone. It's bigger than before the second ablation. Now, let's confirm the ablation zone is big enough to cover all the initial tumor territory. Another example to show you the post-RFA follow-up. Here is a tumor post-RFA 3 months after the RFA procedure, and contrast enhanced ultrasound demonstrated the ablation zone here, but outside the ablation zone, a well-enhanced area suggestive of regional recurrent or tumor progression. CT also confirmed the ablation area here, and tumor local ablation, tumor progression here. So another case to show you a tiny recurrent area adjacent to the margin of the ablation zone. And in this case, that's demonstrated a good treatment efficacy, so no local recurrence. So regarding the efficacy of RFA on HCC guided with contrast-enhanced ultrasound, we try to confirm that contrast-enhanced ultrasound is better than conventional ultrasound guided procedure. So we collect 133 lesions. 57 were group A and 55 patient group B guided with a conventional, and 57 guided by using contrast-enhanced ultrasound. And we found that contrast-enhanced ultrasound can achieve higher complete ablation rate, up to 95.6%, while in the conventional ultrasound guided group, just about 89%. And the p-value is less than 0.05, so suggestive of contrast-enhanced ultrasound play an important role in both prior and after RFA operations. Why contrast-enhanced ultrasound is helpful in RFA treatment and follow-up? Because contrast-enhanced ultrasound can delineate the ablation zone precisely, and sinusoid can permit the real-time observation, and also for the Cooper phase to provide us more time for evaluation of the other part of the liver, not only the target lesion. And RFA procedures may be repeated if the assessment post contrast enhanced RFA post contrast enhanced assessment demonstrated there are some areas with suspicion of recurrence or incomplete ablation. And the cumulative local tumor recurrence rate at 5 years after CEUS assessment shows 2.3% of recurrence rate only. This also support that contrast-enhanced ultrasound is very important for evaluation of RFA treatment. And the local tumor recurrence rate after assessments with CT or MRI assessment range from 3.2 to 36.6%. So contrast-enhanced ultrasound can be quite useful. And in order to demonstrate that CEUS will be helpful for guidance of RFA, we do a systemic review and a meta-analysis in the past 3-4 years, and we got the conclusion that RFA guided by using CEUS has advantages in improving ablation rate, overall survival rate, and the non-tumor progression survival rate, and so on. This review. And in conclusion, we would like to stress that CEUS have certain pros, because ultrasound guidance is quite convenient with high availability and more cost-effective. It can improve ablation rate, overall survival rate, and the non-tumor progression survival rate, and lower the complication and the local recurrence rate, and the short learning curve, relatively less affected by operators' experience. However, there are some cons, including some difficult locations or operator dependency, and contrast enhanced ultrasound is recommended with diagnostic algorithm in only Asian and Italian guidelines. The availability of sinusoid is limited. So we would like to say proper use of contrast enhanced ultrasound will benefit patients. And thank you so much for your kind attention. Thank you.